We are going to discuss diagnostic laparoscopy, what are the indications, how to position the patient, how to make ports in the abdomen, what are the safety measures that we should take, and complications of the procedure. So the laparoscopy, lapra means flank side and scope meaning to visualize. So the diagnostic laparoscopy is a minimal access surgical procedure that allows the visual examination and the documentation of intra-abdominal organs in order to detect the pathology by two ports. The history of laparoscopic surgery, how it was introduced. The first laparoscopic surgery was done by Dr. Killing in 1901, and he performed it on a dog. Then a Swedish internist named Dr. Jacobus is credited with performing the first diagnostic laparoscopy on human in 1910 for ascites. The father of laparoscopy is Dr. Kurt Semen, who invented the automatic insufflator in 1966. The insufflator means to introduce gas into the abdominal cavity to distend it so that we can visualize the internal organs. Dr. Johannes VERESS, he developed a spring-loaded VERESS needle with an inner stellate that automatically converted the sharp cutting edge to a rounded edge. This needle is introduced into the abdominal cavity either within the umbilicus or just above the umbilicus so that we can introduce the gas into the peritoneal cavity to make the pneumoperitoneum. Then father of modern laparoscopy is the Dr. Cameron Nazard, who is not only the laparoscopist, he is also a hysteroscopist. He is known as father of operative video laparoscopy. When should we think of doing the diagnostic laparoscopy? Number one is the infertility workup. If we have a patient with infertility, we would like to know whether she has peritubal adhesions. We want to do the chromoperturbation. We are in doubt of endometriosis, or we want to know the ovulation stigma of the ovary. Number two, if patient has a chronic pelvic pain which is not responding to any conservative management, and we are not able to come to the conclusion what is the basic pathology, so we do the diagnostic laparoscopy to find out the etiology of the chronic pelvic pain. Third is the nature of the pelvic mass. Suppose we have a pelvic mass, we would like to know whether it is a fibroid, whether it is an ovarian cyst. Then to diagnose an acute pelvic lesion like acute salpingitis, acute appendicitis, ectopic pregnancy. Follow-up of the pelvic surgery, especially the tuboplasty, ovarian malignancy, evaluation of the therapy in endometriosis. This is known as the second look surgery. Investigation protocol of the amenorrhea. We have a patient, we want to know whether she has Mullerian abnormalities like bicornuvate uterus, subseptate uterus. We would like to do the diagnostic laparoscopy. The laparoscopy equipment, it consists of an imaging system, instruments for creating the pneumoperitoneum, and the surgical instruments. This is the trolley that you will see at the foot end of the patient. It has, this is the trolley that stays with the foot end of the patient. It has the insufflator through which we introduce gas into the peritoneal cavity to create pneumoperitoneum. This is the light source that is used for visualization of the pelvic organs and for recording. This is the monitor on which we see the pelvic organs. This is the camera control here for. This is the suction irrigation system that is used during surgery, and this is the dithermy controller which delivers the electrosurgical current, and here is the video recorder. The imaging system, it consists of the various parts like light cable, which is of two types, fluid filled cable and fiber optic. We usually prefer fiber optic cables. Then we have fluid filled cables that conduct more heat, they are stiffer in nature, they cause hindrance in maneuvering angled scopes, inability to autoclave. That is why we prefer the fiber optic cables. They are user friendly, although they are expensive, but you have to handle them with care because they are very fragile, and fiber damage of more than 25% is there. We have to replace the cable. That is why we have to be very careful, but we have advantages also with the fiber optic cables. Then imaging system also includes the laparoscope. This is made of the surgical stainless steel containing an optical lens system at the end comprising of aligned glass lenses and spacers. It has rod lens system within the barrel. The laparoscopes, they come in various sizes for different purposes, like we have 10 mm, 5 mm, 2 to 3 mm, even needle scopes, and with various visualization capabilities such as 0 degree forward viewing and 30 degree and 45 degree telescopes. These are the telescopes. Like this is the barrel, this is the rod lens system inside the barrel, and this is the lens here. In this case, this is the 30 degree, and this is the light source. Here we connected the light source. This is the light post that is connected to the fiber optic cable, and this is the eyepiece through which we visualize, and here we attach camera to it. Then we have the camera unit. The most important and vital part of the imaging system is the camera unit, which is attached to the eyepiece of the telescope. The sensor called CCD, which is charged coupled device, has a small piece of the silicon called pixels that are arranged in rows and columns and are sensitive to light. That means we have to go for white balancing, zoom option, digital enhancement. It creates the sharper image and contrast enhancement. Disadvantage is the development of grains that distort the quality of the image, and the disadvantage of present day camera is 2D vision, which has the loss of the depth perception. Then we have another important part of this is the video monitor. Video monitor, it is the high resolution TV sort of thing that is suitable for the production of the endoscopic image. We have 3 chip cameras that require monitors with 700 line resolution to realize the improved resolution of extra chip sensors. We have VHS recorder, video printer, and sometimes DVD recorder. They are the standard documentation equipments, and standard resolution monitors, they have a resolution of 400 lines. High definition monitors, they have 1200 lines, which gives a better image. So this is the monitor that is the choice for the HD visualization. Then instruments for the pneumoperitoneum. This is the VERESS needle. Okay, this is the outer sharp edge. This one, it acts just like the knife. It has sharp edges that cuts the skin sheath till it reaches the peritoneum. And this is the spring-loaded barrel inside this. It prevents injury to the sharp, because of the sharp tip, it prevents injury to the vessels and the visceral organs. So this is the barrel inside, barrel, and this is the needle. So this is spring-loaded like this. It has a blunt tip that is retractable into the sharp tip. This is the blunt tip. that retracts when it comes in contact with the skin or with the sheath. Because of the resistance, it retracts inside the barrel, and this tip, sharp tip, it penetrates the skin, the sheath, the peritoneum. This is just to prevent the injury to the internal organs, visceral organs, and as well as to the blood vessels. So it has a diameter of 2 mm and length is 12 to 15 centimeters. The insufflation that up to 1.5 to 21 per minute. Is that 1.5 is the liter for 21 minutes. This is the machine which is known as the insufflator machine. It reads how much air we have introduced into the cavity, peritoneal cavity, what is the rate of flow, how much gas is flowing through the needle in 1 minute, and what is the actual pressure within the peritoneal cavity. Now, we have already discussed what are the indications of laparoscopy. Now, what are the contraindications of laparoscopy? Suppose we have a patient who comes to us and asks us wants laparoscopy, but should we go or not? That we have to decide. So these are the contraindications in which we should refuse the laparoscopy, like severe cardiopulmonary disease, because we are using the pneumoperitoneum, it can create the problems further. If patient is hemodynamically unstable, if she has generalized peritonitis, if significant hemoperitoneum is there, if she has intestinal obstruction, extensive peritoneal adhesions, large pelvic tumor, pregnancy more than 16 weeks, advanced malignancy, and if patient is on anticoagulation therapy. So the pre-operative evaluation, when a patient comes to us, we have given her this option for diagnostic laparoscopy, what investigations we should follow. Number 1, the blood investigations, complete blood count, routine urine and microscopy, serum thyroid stimulating hormone, random blood sugar, HIV test, HBsAg test, VDRL, SGOT, SGPT for liver function, PT-INR to know the coagulation status of the patient, serum creatinine and blood urea, know the kidney function, serum electrolytes, ultrasonography, chest X-ray, PA view, ECG. Then positioning of the patient. How are we going to position the patient? That depends upon whether we are doing the hysteroscopy or whether we are doing the laparoscopy. Suppose let us say we are taking the patient for the diagnostic laparoscopy. This is the position that we have to put patient in. But since we know that it may take long time and it can injure the patient's nerves, so we have to minimize that. How? By using the pressure, by using the pads on the points where there is maximum effect of the gravity. This is just to avoid the nerve damage and undue traction. Like in this, the position of the arms are positioned at the patient's side by abduction and pronation to allow freedom of the movement for the surgeon. The operating table should be horizontal at the start of the procedure, and abdomen should be palpated to check for any masses before insertion of the VERESS needle. Then this is the position of the surgical team. This is very important. Like this is the patient over here. This is the surgeon on the patient's left side. Anesthesia team will remain here. This is the assistant one. This is the technician, scrub nurse along with the instrumental trolley. And here there is another assistant that will stay at the vaginal end, and we have 2 monitors. One is for this assistant that will remain here, and one is here that will remain for the surgeon. So port side stent, that will be discussed next time when we discuss the surgery. I hope you understood this very well. If you have any questions, please you can post the questions, that will be answered. Thank you for your patience.